The number 80 milligrams per deciliter might sound like just another routine figure on a standard blood report, but it represents the exact threshold where almost everything medicine has taught us about high-density lipoprotein, or HDL, completely shifts. For more than 4 decades, patients, physicians, and health pamphlets have repeated the exact same message. HDL is the good cholesterol, and the higher your level goes, the safer your heart will be. But modern cardiovascular science has uncovered a dramatically different reality. In 2017, landmark research tracking more than 116,000 individuals over several years published findings in the European Heart Journal that fundamentally challenged this long-held belief. The data revealed that individuals with exceptionally high HDL levels did not experience the lowest rates of mortality. Instead, they exhibited some of the highest risk profiles, matching or even exceeding the mortality rates of individuals with dangerously low HDL levels. This unexpected outcome applied equally to both men and women. If you are an older adult who has spent years taking pride in an unusually elevated HDL reading, or if your physician has previously congratulated you on a high score, it is time to re-examine those results through an updated scientific lens. The core finding is straightforward. The relationship between HDL cholesterol and overall mortality is not a continuous straight line pointing downward toward safety. It forms a U-shaped curve. Extremely low HDL carries well-documented cardiovascular risks, but extremely high HDL carries its own distinct set of risks. The optimal range for health and longevity resides comfortably in the middle, generally between 40 and 80 milligrams per deciliter, depending on biological sex and individual risk factors. Once your reading climbs above 80 milligrams per deciliter, the conventional protective narrative begins to fall apart. My name is Dr. David. On this channel, my goal is to analyze published clinical trials, cohort studies, and mechanistic research, translating complex medical science into clear, actionable insights for adults who want to understand their health beyond a brief pamphlet. I am not your personal physician, and this information serves an educational purpose rather than a direct medical prescription. However, every study, clinical trial, and physiological process discussed today represents verified scientific literature. To understand how this U-shaped curve impacts real lives, consider the situation of a gentleman named Walter. Walter is 74 years old, lives an active lifestyle, walks his dog twice daily, and stays diligent with his annual medical checkups. For decades, his standard lipid panel featured one line that always brought reassurance: his HDL cholesterol. In his 50s, it registered at 68 milligrams per deciliter. By his 60s, it reached 79. At his most recent physical, his HDL registered at 91 milligrams per deciliter. His doctor looked over the results and offered the standard praise, noting that his good cholesterol was outstanding. Walter's ex-wife had an HDL reading of 54, and over the years, Walter occasionally poked fun at her lower score, genuinely believing his high number acted as an impenetrable shield against heart disease. However, when Walter began looking closely at the recent medical literature, he discovered the Copenhagen cohorts, containing over 116,000 participants, which demonstrated that men with exceptionally high HDL had significantly higher all-cause mortality compared to those in the middle range. He also discovered the Canadian CanHeart study, which analyzed over 600,000 individuals without prior heart disease and confirmed the exact same U-shaped pattern. Looking at his own lab report of 91 milligrams per deciliter, Walter realized his number sat well beyond the optimal safety zone identified by both large-scale studies. It is crucial to clarify that observational studies show associations rather than direct cause and effect relationships. A very high HDL reading does not automatically mean the cholesterol itself is actively causing harm. It can sometimes serve as a biomarker for underlying genetic factors, metabolic changes, or heavy alcohol consumption. What Walter realized, however, was that the foundational assumption keeping him feeling secure, that a higher number is always better, had completely dissolved in modern cardiology. This realization is particularly relevant for older adults, as elevated HDL readings become increasingly common with age, especially among women. Yet, the chances that a routine medical appointment will cover the nuances of this U-shaped curve remain exceptionally low. To comprehend why an abundance of good cholesterol can cease to be beneficial, we must examine what an HDL particle actually does inside the cardiovascular system. Cholesterol itself is not an inherently harmful substance. Your body requires it to construct cellular membranes, synthesize essential hormones, and produce vitamin D. The primary concern lies in how cholesterol is transported and where it accumulates. Low-density lipoprotein, commonly known as LDL or bad cholesterol, carries cholesterol from the liver out to the peripheral tissues and artery walls. When LDL levels are excessively high, or when the particles become oxidized, they can deposit cholesterol into the arterial walls, initiating the formation of inflammatory plaque. High-density lipoprotein, or HDL, has traditionally been viewed as the cellular cleanup crew. Each HDL particle functions essentially like a microscopic waste removal truck. It travels to the arterial wall, extracts excess cholesterol from local cells, and transports it back to the liver for clearance and excretion. This critical clearing process is known medically as reverse cholesterol transport, and the specific ability of these particles to pull cholesterol out of cells is called cholesterol efflux capacity. This brings us to a major limitation of standard blood tests. A routine lipid panel does not count or evaluate the functional capacity of the transport trucks themselves. Instead, it measures the weight of the cargo inside them. The number listed as HDLC on your lab report simply represents the total concentration of cholesterol carried within all HDL particles at the moment your blood was drawn. It offers zero information regarding whether those transport trucks are actively working, idling, or entirely broken down. Recent comprehensive reviews in cardiovascular medicine emphasize that HDL particles can become dysfunctional. These altered particles remain present in the bloodstream and continue carrying cholesterol, which keeps your lab result high, but they have lost their structural integrity and functional capability. Under conditions of chronic low-grade inflammation, metabolic dysfunction, or oxidative stress, the surface proteins on HDL particles undergo chemical modifications. When this happens, the microscopic truck remains parked on the street with its loading arm completely broken. In certain altered states, dysfunctional HDL particles can even reverse their normal role, actively promoting inflammation within the arterial wall rather than resolving it. Imagine an arterial wall in a 75-year-old individual with an HDL reading of 90 milligrams per deciliter. Under the old medical interpretation, a score of 90 meant 90 active clearance trucks keeping the arteries pristine. Under modern cardiovascular science, that high number simply reveals a large amount of cholesterol packaged in HDL particles, without indicating whether those particles are functioning correctly or merely circulating as useless cargo. The raw concentration alone cannot distinguish between a highly active clearance system and a stagnant pool of dysfunctional particles. This physiological reality sets the stage for one of the most expensive research failures in pharmaceutical history. During the mid-2000s, major drug companies invested billions of dollars into developing medications designed specifically to raise HDL cholesterol levels, operating under the assumption that artificially elevating the good cholesterol would automatically translate into fewer heart attacks and strokes. The strategy focused on inhibiting an enzyme known as cholesterol ester transfer protein, or CETP. By blocking CETP, researchers were able to dramatically increase circulating HDL levels in human clinical trials. One of the primary flagships of this class was a drug called torcetrapib. When administered to thousands of patients in large-scale clinical trials, the drug performed precisely as engineered from a numerical standpoint. Patients saw massive, impressive spikes in their HDL cholesterol levels. However, the clinical outcomes were catastrophic. The massive trial had to be abruptly terminated because patients taking the HDL-raising drug were not experiencing fewer heart attacks or living longer. In fact, mortality rates in cardiovascular events were higher in the treatment group compared to those receiving a placebo. Subsequent attempts with other CETP-inhibiting compounds yielded similarly disappointing or neutral results. These high-profile pharmaceutical failures proved what basic molecular biology was beginning to suspect. Simply increasing the total quantity of HDL cholesterol riding around in the blood does not guarantee cardiovascular protection. It is the functional quality and clearing capacity of the particle, rather than its static concentration, that dictates whether it guards your arteries against disease. Genetic science reached the exact same conclusion through a research methodology known as Mendelian randomization. Scientists can analyze large populations by comparing individuals who carry natural genetic variants that permanently elevate their HDL levels against individuals without those specific genetic traits. Because these genetic variations are distributed randomly at conception, this method mimics a lifelong clinical trial designed by nature. If a high HDL level were inherently protective, individuals genetically predisposed to higher HDL should naturally experience far fewer heart attacks throughout their lives. Yet, extensive Mendelian randomization studies published across major medical journals have repeatedly shown that individuals with genetically elevated HDL do not possess an inherent protection against coronary artery disease. When you unite these three distinct lines of evidence, the observational U-shaped mortality curves, the failed clinical trials of HDL-raising medications, and the lifelong genetic data, the conclusion becomes undeniable. The standard HDL number on a lab report is not the primary mechanism of protection. It was merely a proxy marker that worked reasonably well within average ranges, but fails completely at the upper extremes. The practical impact of this scientific shift becomes clearer when evaluating how high HDL interacts with different health profiles. Consider a composite case of an artist named Eleanor, who is 78 years old and maintains an HDL level of 96 milligrams per deciliter. Women naturally maintain higher average HDL levels than men due to estrogenic influences earlier in life. Because of this baseline difference, the boundary between a healthy, reassuring level and an excessively high reading sits at a slightly higher threshold for women, though the risk curve ultimately curves upward for both sexes. Additionally, Eleanor enjoys a daily glass of wine with dinner. Alcohol consumption is known to stimulate the liver to produce higher quantities of HDL cholesterol, which elevates the total number appearing on a routine blood test. However, alcohol-induced HDL elevation does not automatically improve the functional quality or cholesterol efflux capacity of those particles. Her score of 96 may simply reflect an altered metabolic pathway rather than a superior cardiovascular defense system. Next, consider a 69-year-old man named Raymond, who previously suffered a heart attack and had 2 coronary stents placed 5 years ago. His current HDL reading sits at 86 milligrams per deciliter. For years, Raymond assumed that his high HDL was compensating for his underlying heart disease. However, a major study published in JAMA Cardiology specifically evaluated individuals with established coronary artery disease and discovered that an HDL level above 80 milligrams per deciliter was associated with an increased risk of mortality within this vulnerable population. In individuals with existing vascular disease or systemic inflammation, extremely high HDL frequently signals altered particle function rather than robust protection. If you have a history of heart attack, stent placement, or bypass surgery and your HDL exceeds 80, this dynamic deserves a focused conversation with your cardiologist. Finally, evaluate a third scenario involving a 71-year-old woman named Doris, whose HDL reading has hovered consistently around 52 milligrams per deciliter for over a decade. Doris spent years feeling subtly anxious about her reading, constantly trying various dietary hacks and supplements because a doctor once told her she should try to push that number higher. When analyzing the large cohort studies, an HDL reading of 52 places Doris squarely in the middle of the U-shaped curve, the exact zone associated with the lowest overall mortality rates. Doris spent 15 years attempting to force a lab value upward, unaware that her starting position was already within the optimal biological sweet spot. These scenarios illustrate that an elevated HDL reading should not cause panic, nor should it be blindly celebrated. It simply requires a more nuanced interpretation tailored to your complete health profile. To put this knowledge into practical use, there are 5 logical steps you can take regarding your cardiovascular health. First, access your actual medical records and look up your precise HDL reading rather than relying on memory. If your score sits between 40 and 80 milligrams per deciliter, your results fall within the statistical sweet spot identified by current population data, and the concerns surrounding extreme highs do not apply to you. If your reading is above 80, and particularly if it exceeds 90 milligrams per deciliter, it is not a diagnosis of disease, but it does serve as a valid reason to ask your healthcare provider more detailed questions during your next visit. Second, reevaluate any deliberate efforts aimed solely at forcing your HDL number higher. The clinical trial data showed clearly that raising the raw concentration of HDL cholesterol does not automatically confer heart protection. While you should never alter or discontinue any prescribed medication without direct guidance from your physician, it is entirely reasonable to ask your doctor whether any specific supplement or dietary habit you maintain for the sole purpose of raising HDL remains necessary under modern guidelines. Third, redirect your attention toward the markers on your standard lipid panel that possess stronger, unequivocal evidence. The evidence supporting the reduction of LDL cholesterol and non-HDL cholesterol as a primary method for lowering cardiovascular risk remains absolute. Lowering dangerous ApoB-containing particles actively prevents plaque accumulation within artery walls. If you have a limited amount of time to focus on your lab results, prioritizing your LDL, triglycerides, and total cholesterol yields far greater clinical value than obsessing over your HDL. Fourth, prepare a clear, constructive question for your next medical appointment. You can simply say, "My HDL reading is above 80 milligrams per deciliter, and given the recent research regarding high HDL levels, I wanted to ask if this changes how you view my overall cardiovascular risk profile." Phrasing your inquiry this way demonstrates an awareness of updated scientific literature, transitions the discussion away from outdated assumptions, and invites your physician to assess your comprehensive risk profile, including blood pressure, blood sugar, kidney function, and family history. Fifth, focus your practical daily efforts on lifestyle habits that optimize cellular function and reduce systemic inflammation, rather than chasing specific laboratory targets. The factors that cause HDL particles to become dysfunctional, such as chronic systemic inflammation, smoking, unmanaged hypertension, elevated blood sugar, and physical inactivity, are all modifiable. Engaging in regular physical activity, such as daily walking, maintaining a balanced diet, rich in whole foods, achieving a healthy weight, and controlling metabolic parameters directly protects the vascular lining and supports overall cellular health. These foundational habits improve how your cardiovascular system operates at a functional level, which is vastly more important than forcing a single lab metric into an arbitrary range. In the scientific community, researchers have largely shifted away from measuring static HDL quantities and are focusing heavily on functional testing, such as measuring cholesterol efflux capacity directly. While efflux testing currently remains primarily a research tool rather than a routine laboratory test, understanding its existence helps illustrate where modern preventive cardiology is headed. The quality and functional capability of your vascular transport system matters far more than the raw concentration recorded on a routine blood draw. For decades, patients were given a simplified narrative that presented HDL as an unlimited good, where higher numbers always equated to better health. The combined weight of massive prospective cohorts, molecular research, genetic studies, and multi-billion-dollar clinical trials has updated that model. The true relationship follows a U-shaped curve, where optimal outcomes reside in the middle and functional capability supersedes sheer quantity. Taking an active, informed role in understanding these distinctions allows you to engage in far more meaningful conversations with your doctor, focusing your time and energy on proven strategies that genuinely support long-term cardiovascular health and overall well-being.